Hi everyone, thanks for listening to my presentations. Today I'll be talking about hypernatremia. If you haven't listened to the presentations on hyponatremia, please kindly do. I have 3 published on my channel. But today, the whole attention will be on hypernatremia, and I'll be going through causes, symptoms, diagnosis, and treatment. Okay, let's go. Hypernatremia simply means the serum sodium is greater than 145 milliequivalent per liter. And if someone will ask me, what would be the normal range? If you have listened to hyponatremia presentations, you would have gotten that far. But I will not be lazy to skip that here. The normal range is between 135 to 145 milliequivalent per liter. Some literature will put 147 milliequivalent per liter. Of what importance is this topic? Well, tonicity is the ability of solution to alter the volume of cells by changing their water content. In hypotonic environment, cells will gain water and then swell up. Remember, from the elementary biology or high school biology, depending on where biology starts with you, we've been taught that cells will form tissues. Tissues will form organs, and organs will form the body systems. And all the body systems put together will form the whole human being. And we were also taught then that a cell is the basic or fundamental unit of life. If a cell is the fundamental unit of life, then it is not out of place to dedicate a lot of hours studying everything about the cell. And today, I'll be talking about the environment that the cell could be found. In hypertonic environment, like in hypernatremia, cells will lose water and shrink, and we don't want that. Okay, still more on tonicity, the concentration of sodium and other solutes would determine the tonicity of the extracellular fluid, which means solutes like sodium, glucose, chloride ions, bicarbonate ions, plasma proteins, and so on will play a part here. And we are going to be dealing with one of the 3 possible tonicity conditions. It's either we are dealing with hypotonic environment, isotonic, or hypertonic. In isotonic extracellular fluid, as far as sodium is concerned, it means the sodium will be between 135 to 145 milliequivalent per liter, without putting other solutes in excess as well. Okay? In hypotonic extracellular fluid, as far as sodium is concerned, it means the value of sodium will be less than 135 milliequivalent per liter. You can check my channel for all the publications or presentations on hyponatremia. Then you get all those facts about that. Okay? So the decreased sodium in hypotonic environment may not cause hypotonic state if the value of glucose, proteins, and lipids are high. Okay? Now, as far as today's presentation is concerned, hypertonic ECF, as far as sodium is related, will be hypernatremia, meaning the level of sodium in the serum will be greater than 145 milliequivalent per liter. And that could also be caused by hyperglycemia, but I'm limiting this presentation to hypernatremia. We don't want that, because at this state, the cells could shrink. We'll be mentioning ADH in the course of this presentation. Therefore, I'll briefly go over what ADH is all about so that we'll have an idea by the time I'll be repeating the name ADH all through. ADH is also known as Arginine vasopressin or vasopressin or antidiuretic hormone, simply called all those names. It is synthesized in supraoptic nuclei of the hypothalamus and stored in the posterior pituitary. There are two hormones stored there. The other one is oxytocin. That is why oxytocin will also have antidiuretic effect. The key role of ADH is blood pressure regulation. Also plays vital role in osmotic balance and sodium homeostasis, and that is what we are doing right now, sodium homeostasis. ADH is also involved in kidney function because the vasoconstrictive effect and the effect on the kidney to store more water will help in blood pressure regulation. In tonicity homeostasis, hyperosmolar state will trigger the release of ADH, just as this case is today. Okay, in hyperosmolar state, there will be release of ADH. Then that will act on the kidney to increase water absorption to balance the medium. That is what we will expect today. In hypovolemia or volume depletion, ADH will sense the drop in blood pressure, and that will lead to increase in water reabsorption in the kidney and vasoconstriction of the blood vessels. These combined forces will synergistically increase the blood pressure. Lastly, in hypovolemia, ADH will be secreted even in hypoosmotic states. However, hypervolemia or hyperosmotic hypervolemic state will inhibit ADH secretion. So we have brief info as far as ADH is concerned. I will dedicate a separate presentation that will cover the entire lecture on ADH in the nearest future. Epidemiology. As far as hypernatremia is concerned, hypernatremia will be found in about 1 to 2% of inpatients. That is, those that are admitted in the hospital. And this will be very common among the elderly on admission. What are the causes of hypernatremia? Actually, if you have listened to the presentations on hyponatremia, we'll be going the opposite direction today. Okay? Hyponatremia and hypernatremia are just like words and opposites. So, inadequate free water intake, severe exercise, hyperaldosteronism, Cushing's syndrome, seizures, sodium bicarbonate infusion, intake of hypertonic saline or IV infusion of hypertonic saline. Intensive care unit will lead to acquired state, hemodialysis, saline enema, and of course, tablet sauce. If you have gone through the treatment of hyponatremia and you are now on this page, you'll discover there are some measures that we can take in correcting hyponatremia might tilt to hypernatremia. Still on causes, insensible loss of water, sweat loss, GIT loss like diarrhea, central diabetes insipidus in head injury, nephrogenic diabetes insipidus, osmotic diuresis like in case of presence of glucose in hypoglycemia or urea in the presence of high protein tube feeding, monitor or recovery from isothermia. Still on causes will be hypothalamic lesions affecting the test and osmoreceptor. And of course, the primary hypodipsia. If you have followed my channel and you've listened to causes of hyponatremia, there I have made reference to primary polydipsia. Now, this is primary hypodipsia. Okay, the opposite of what is causing hyponatremia. So this individual is drinking less deliberately. Less water. Reset osmostasis, affecting the mineralocorticoids in excess. The patho here is essentially that we'll be having excessive sodium intake or increased sodium retention with excessive water loss. And then there will be poor response to water loss, for example, decreased ADH, and there's lack of test response as well, which will lead to inadequate water intake. And then we'll be left with total body water deficit that will be greater than total body sodium deficit. What are the possible symptoms? Nausea, vomiting, anorexia, weakness of the muscles, lethargy, tachypnea, restlessness, high-pitched crying in infants that could be wrongly diagnosed as kernicterus if the value of bilirubin is not acid. Still part of the symptom could be hyperreflexia, spasticity, seizures, confusion, coma, and if no treatment on time, death. 3 types of hypernatremia could be found. Either hypovolemic hypernatremia, where we'll be dealing with decreased total body sodium when we compare that to water. And why that? There's likelihood of more water loss than sodium loss. Okay. In isovolemic or euvolemic hypernatremia, we'll be dealing with normal total body sodium level, okay? Which means the individual is drinking more hypotonic fluids. In hypervolemic hypernatremia, there is high level of total body sodium. That is a very rare condition. Here, more sodium intake is occurring than the level of water intake. And that could be found in situations where we give sodium bicarbonate or we administer hypersaline infusion. Investigations. First thing first, we have to assay for the level of all the electrolytes. Particularly, we'll be focusing on the value of sodium. And here, as far as hypernatremia is concerned, the sodium level will be greater than 145 millimoles per liter or milliequivalent per liter. Some authorities, some other literature will put it as 147 milliequivalent per liter. The higher the value of sodium above 145 milliequivalent per liter, the worse the symptoms. So we'll get the serum and we'll be looking for the value of sodium, potassium, glucose, blood urea nitrogen, and creatinine. So we want to know what is happening to the renal system, right? We want to know calcium and phosphate level, and of course magnesium. Let me digress a little bit. If we are faced with low level of magnesium, the patient could die of that rather than the effects of hypernatremia, because hypomagnesemia will lead to toxar de point, from prolonged QT, and tosaldi point can become ventricular tachycardia if it's not corrected, and polymorphic ventricular tachycardia could become ventricular fibrillation. If there is no defibrillation, ventricular fibrillation could lead to asystole, and without code blue being called, an advanced cardiac life support system instituted on time, the individual could end up in the morgue. And we will check for the value of the electrolyte in urine as well. Okay, we want to know the level of sodium there, potassium, chloride ion, calcium, glucose, and so on. Okay, we'll do something more than what we did under hyponatremia here. We'll have serum osmolarity estimated. The normal level of serum osmolarity is between 280 to 300 milliosmoles per kilogram of water. And how do we make that determination mathematically? So that you can pause and read through here. You get your sodium, your glucose, your blood urea nitrogen, ethanol or mannitol combined, or some literature will limit it to value of sodium and potassium, glucose, and blood urea nitrogen. You can pause to see the mathematical expression. Still on investigations, we will move a step further to determine free water deficit. We will first get normal total body water in liter, and then know what the current total body water in liter is. Then we'll be able to determine the free water deficit mathematically by following a simple calculation as free water deficit is equal to the difference between normal total body water and current total body water. That is, you take away the value of the current total body water from the normal total body water in liter, and whatever you get is the free water deficit. Still on investigations, we have to determine if the kidney is excreting or retaining electrolyte-free water. Then we can do this by finding out that the kidney is having the capability to concentrate the urine, meaning that urine electrolytes are greater than serum electrolytes. Or the kidney is diluting the urine, meaning that urine electrolytes are less than the serum electrolytes. Complications. This is hypernatremia, right? The cells could shrink. And what would that mean? There could be cerebral hemorrhage. For example, the affected individual could be complaining about the worst headache of his or her life, and that will be pointing to subarachnoid hemorrhage. We might be faced with subcortical hemorrhage as well. It's likely that the individual could have venous sinus thrombosis, and with that, the mortality will be very high, particularly in acute hypernatremia with venous sinus thrombosis. The mortality rate could be as high as 40 to 60%. However, the value will be a little bit decreased in chronic hypernatremia, but we don't want anybody dead, right? So in chronic hypernatremia, venous sinus thrombosis could lead to mortality in 5 to 30% of affected individuals. So the complications are very horrible. Treatment. The goals are no rapid reduction. So we should reduce very, very slowly. Reduction should be between 8 to 10 milliequivalent per liter in 24 hours. Serum sodium reduction should not be greater than 12 milliequivalent per liter per day, and 1 milliequivalent per liter per hour is the required level if the case is acute. If we are dealing with chronic hypernatremia, it is okay in 1 hour to have reduction at the rate of 0.5 milliequivalent per liter. In other words, the reduction is expected to go at half the rate of acute hypernatremia when we are dealing with chronic hypernatremia. Let me explain myself further here because this is the key of this presentation. We have many diagnoses of hypernatremia. We look out for the causes. Okay? How do we treat? We set the goals because we want to save the lives. We don't want to kill the patient, right? Then no rapid reduction. Go very slowly. Set the target. Reduction should be between 8 to 10 milliequivalent per liter in 24 hours. Regardless of how high the sodium level is, we can't just overdo it, okay? Serum sodium reduction should not be greater than 12 milliequivalent per liter per day. And if you are dealing with acute hypernatremia, we have the privilege of reducing the level by 1 milliequivalent per liter per hour. Okay? In the phase of chronic hypernatremia, we cannot go beyond 0.5 milliequivalent per liter per hour. Still on treatment, we have to discontinue hypertonic saline. And we can grab our diuretics, for example, thiazide, that could induce hyponatremia. But we have to check the electrolyte level so that we will not tilt the affected individual to hyponatremia proper while trying to reduce hypernatremia. But if the volume of fluid is excessively down, we can give IV fluid D5 water. The goal here is 12 milliequivalent per liter per day reduction, not too fast pace. Replace very slowly, particularly if the onset of hypernatremia is greater than 48 hours, meaning we have been treated to chronic hypernatremia already. You have to check the vital signs, the blood pressure, the heart rate, respiratory rate, and of course, we auscultate for pulmonary edema. And with that, we are now administering hypotonic solution, right? D5 water. So we might be faced with pulmonary edema, even cerebral edema. We have to check for the potassium level as well, because hyperkalemia on its own could be a big problem, just as hypokalemia should now be prevented. If we check the potassium level and the blood pressure is increased and the potassium level is low, we have another diagnosis at hand. That is hyperaldosteronism, and we have to address that appropriately. In isovolemic or euvolemic hypernatremia, if it is mild to moderate level, you just advise the individual to increase water intake. But in the phase of moderate to severe, we have to do something more. We have to replace the free water deficit with D5 water, and that should be done slowly over 48 hours as well. very slowly in the face of chronic hypernatremia. If in the fourth and fifth decades of life, that is somebody at the age of 50 something or 60 something, then we'll go more slowly. The serum sodium reduction should not be greater than 12 milliequivalent per liter per day. And we have the luxury of giving 1 milliequivalent per liter per hour in the face of acute hypernatremia, and 0.5 milliequivalent per hour if we are dealing with chronic hypernatremia. Reduction should be between 8 to 10 milliequivalent per liter in 24 hours. You could see that I have repeated this in the last 3 slides consistently. That is the key here, the rate of reduction. Lastly, you can use enteral water sources, and that will be preferred. You can also use tube feeding with D5 water, but don't use half saline, that is 0.5% sodium chloride. And watch out for cerebral edema. With that, I've come to the end of this presentation. Please remember to share, remember to subscribe, and you can leave comment on my channel. I would appreciate that. Thank you.